But just generally speaking, you mentioned medication absolutely can interfere with sleep. Are anti-malarials something that pops up quite a lot in terms of sleep disturbance? And can you say a little bit about that?
They really aren't. If I go through the common drugs that, you know, week in, week out, I might suggest people de-prescribing. I might go really simple and say nasal decongestants contain adrenaline, inhalers. So although you might say, you know, we see about 2,000 patients a year, 2,500 new patients. It really isn't something that comes through a signature within the NHS. Now, of course, there's different people with different expertise speaking. And I think we'd always have to look at the whole prescription. And you know, very much what was happening around the time that you took a tablet. That would generally be my approach. Great.
Okay, well, we have got, that's fabulous. We've got just a couple of minutes just so we've got one more question. In terms of mental health problems and sleep, is there any sort of link between sleep being an early indicator potentially for mental health problems that people might be developing?
Absolutely. And I mean, you know, I'm clearly simplifying this. Very expert psychiatrist talking. It is, of course, a bidirectional relationship. You can talk to people with bipolar. Absolutely. It's their very first warning sign just as they tip into psychosis. And they learn that. And in fact, sedation and controlling sleep makes a big difference. But equally, we flip it the other way and people have well-treated depression, but have awful residual insomnia. And if you improve the insomnia, you decrease their risk of future relapse. So is that
great? Okay, that's absolutely fabulous. Thank you ever so much indeed. That was really useful. So we'll have a chance if anyone has any more questions for Kirsty to ask her those at the panel stage, which is at 11:45. So we're a minute early, which is always good news. So I'm really pleased to introduce our next speaker, who's Professor Ron Behrens. Ron is an honorary consultant at the Hospital for Tropical Diseases, and he ran the first NHS clinic for the Hospital for Tropical Diseases from 1989, so quite a few years ago now. And importantly, he sat on the Public Health England's advisory committee for malaria prevention for the last 20 years. And for those of you who are interested in military mental health, you'll probably hear that from time to time. Lariam, which is also known as Mefloquine, it's an anti-malarial, comes up and indeed has been a topic that the Defence Select Committee have also considered over time. So there are lots of debates about it, and I'm really pleased that Ron is here to sort of give us some detailed expert insight into Lariam and the military and mental health. So thank you very much indeed. Over to you, Ron.
Right. Good morning to you all. Right, this is a controversial area, and I'm trying to keep it as objective as I can. My declaration of interests are there, and I've acted as an expert witness on this for a number of groups. Can I have the next slide, please? So we'll start with a bit about the drug itself, Mefloquine. It's a synthetic quinine methanol developed by the military, the Walter Reed Army Institute in the 60s, developed through the Vietnam War, and then marketed by Hoffmann and Roche in collaboration with the WHO. And it's a very effective drug for killing and preventing chloroquine-resistant falciparum malaria. And when it was introduced in the late 80s, early 90s, it was a sea change from the chloroquine and prevailing, which was beginning to fail both in therapy and prophylaxis, so a big improvement. It was licensed for treatment and for prophylaxis, but it was found that in the doses used for treatment, it had significantly more side effects, and therefore has been very limited use as a treatment, but widely used as a prophylaxis. Now, the problem with doing research into anti-malaria prophylactic drugs, they're easy to do in country where malaria is endemic, but in traveling populations, they're much more difficult because it is very obviously difficult to supervise and monitor travelers in studies, and therefore there are a limited number of traveler studies, but there are many more military studies because they are a sort of supervised, monitored group, and therefore studies are much easier. So there are many more studies in the military populations than there are on travelers. Can we go to the next slide, please? So I'm mainly going to be talking about the adverse events of Mefloquine because clearly it works effectively in its main role as a prophylaxis. And there are different types of adverse events, and I'm showing you here that what an adverse event is basically an unfavorable or unintended symptom or sign from a drug. But it's also to understand the contemporary nature of these events. And we talk about concurrent events, those are events that happen while you're on the drug. We also have occasionally latent events, which are not apparent when you're taking the medication, but are shown to be related at a later stage. And finally, there are the persistent ones that arise when you're taking the drug, but also persist for longer than 20 days after you've stopped the drug. It is important to understand that the drug itself has quite a long half-life of about 13 to 14 days. So it's in the blood for quite a long time, which is why as it has the advantage of only being taken weekly, whilst many of the other drugs you need to take daily because of their shorter half-lives. And being a long-act or long retained medication, some of the effects can last for much longer because of that long half-life. Next slide, please. So in the summary of product characteristics, the data sheet, Mefloquine has the listed side effects or symptoms associated with. And interesting from the last talk, insomnia and abnormal dreams and nightmares is one of the most frequent, and certainly in concurrent use when you're taking the drug, that's the one that most people report to me, that they've had bad nightmares and dreams whilst taking the medication. And that occurs in up to 20 to 30% of users of the drug. But there are many others, and there's anxiety, depression, restlessness, confusion. In 2013, the SPC changed its advice and suggested that any of these signs were a prodromal event for a more serious neuropsychiatric event. And that's an important statement because it suggests that if you have any of these signs, including sleep disorders, you may, they suggest, get more serious neuropsychiatric events. Also, the contraindications of the drug are what I think somewhat ambivalent, where you have a history of psychiatric disturbances, but they don't say what the psychiatric disturbances. For example, is it sleep disorders? They give some examples, depression, anxiety, and schizophrenia, but it's somewhat ambivalent in the SPC. The problem that many of you will recognize, next slide, please, is that many of these symptoms that are described with Mefloquine are common symptoms associated with the general population. This is a study of psychiatric morbidity in the general population by the Office of National Statistics. And I'm sure the previous speaker will agree that sleep problems are one of the most common, but fatigue, irritability, depression, and anxiety are all common in the general population. And therefore the challenge with examining and exploring Mefloquine is, are they random events or are they related to the drug? And this is where the challenge of dealing with Mefloquine is it a causal, or is it an association, or is it just a background effect? And we can try and explore that to find out what is the evidence. Because it's such a large subject, I'm not going to look at concurrent adverse events, but I think there's clear evidence that concurrent adverse events are associated with the drug, and these tend to be insomnia, abnormal dreams, nightmares, acute anxiety, and those are the more common ones. But what about the latent or persistent? And that's where the challenge is. So can we go to the next slide, please? I thought I'd also give you a bit of a background to the situation where we are today. As I've said, the drug was originally licensed in the late 80s, early 90s. But in the mid-90s, there was quite a lot of litigation around Lariam. Watchdog program made a news program or a user affairs program made a statement that Lariam was causing huge problems, and a large litigation group took action, but they had their funding withdrawn in the 1980s. And then in the United States, there were some events where, for example, a soldier killed some colleagues and associates and this was blamed on the fact that the soldiers had been using Lariam. And this resulted in the United States commissioning a research into the effect of Lariam, and subsequently there's been a lot of reviews, committees looking at the role of Lariam in neuropsychiatric disorders in the military, and I've listed many of them, and we'll talk about some of them later on. The largest studies to examine this were mainly commissioned by the US military. They are as effective studies as can be done within their circumstances, and I'll talk about those in a later date. The most recent analysis was done by the National Academy of Sciences of Medicine and Sciences in the United States, and I'll talk a bit about that at the end as well. So that's the spectrum of where we are today. The other point I want to make is that the European Medicines Agency changed the data sheet for Lariam in 2013 to suggest that it was more, the neuropsychiatric were more serious than had been shown previously. Next slide, please. So I'm going to start by looking at what is said against Lariam, and one of the biggest critics is a doctor called Remington Nevin. Next slide, please. And you can read what he says. This is in a chapter he's written about what it causes, and it's toxic encephalopathy. And he talks about chronic effects. He talks about brain damage. He talks about toxicity of the limbic system. He talks about mood disorders, personality change, psychosis, and so on. So he has a huge range of issues with the drug, and he has founded a pressure group called Kunism Foundation, which is against Mefloquine and other quinolone drugs, because they think there's a chronic encephalopathy related to their use. Next slide, please. Of importance, though, he says that many of in the military, the disorders of PTSD may be Mefloquine related, and he says that it's not being recognized that the link between the two is that the Mefloquine may be the cause of the PTSD and confound the diagnosis. Currently, there are a number of Lariam action groups who have various litigations and compensation claims, and I just used one that I found on the web, but certainly there are a number of groups who are trying to support claims from soldiers who have very many of the symptoms that I've described. Next slide, please. So I'm going to, because of the time, I'm going to summarize some of the best studies that we have available, where there are comparison groups. There's a clinical diagnosis, there are large sample sizes, and there are other covariates included, such as deployment and non-deployment and gender and so on. And just give you what the evidence that I see exists, and then summarize at the end. So next slide, please. So one of the biggest studies is, again, from the US military. It's a retrospective study in active members. You can see that they've looked at deployed and non-deployed military personnel, and using a number of drugs such as Mefloquine, atovaquone, prodromal, that's AP and doxycycline, and they were looking at neurological and psychiatric disorders. The next study, next slide please, is again from the US military. This was an earlier study. It was mainly looking at hospitalization of military personnel, looking at their diagnosis and looking at their what they've been prescribed, and making comparisons between active duty members and non-active members, and again looking at a whole range of neuropsychiatric events. And again, the numbers here are large. Next slide, please. And again, a more recent one, looking at the chronic neuropsychiatric events in, again, large numbers of US military, looking at deployment, looking at the drugs used, and so on. And again, they're looking at chronic disorders. I'll summarize their findings when I've gone through all the studies. Next slide, please. Then there are 2 UK-based studies. These are based on the UK General Practice Research Database, and they look at individuals who'd been prescribed anti-malarial drugs and then who had a diagnosis in the future of a neuropsychiatric nature. And so again, there were quite large numbers of them, and there were 2 similar studies done in different periods, again looking at subsequent diagnosis to the use of an anti-malarial in primary care practice. And the final important study, I think, is a Cochrane review. Next slide, please, which looked at, it was a very large study, but I just wanted to highlight that they looked at the drugs effect with the military and non-military. And what was interesting, of course, in this analysis, they found no difference between the military and non-military prevalence of side effects and discontinuation of drug, suggesting that the way the population behave is not necessarily entirely dependent on their jobs or the type of persons they are. What were the main findings? And again, I really had to summarize a huge amount of findings, so can we have the next slide, please? In the ICOS study, next slide, please. The summary is that Mefloquine users had similar neuropsychiatric events to doxycycline and atovaquone prodromal. And what was interesting in this study is that in some of the military personnel who had psychiatric illness, they did not have a higher rate of psychiatric disorder subsequent to the use of Mefloquine, which is what the contraindication of the drug says you shouldn't be given to somebody with neuropsychiatric disorder. But it appears in this study, and there were quite significant numbers, it didn't exacerbate their underlying diagnosis. Next slide, please. In the Wells study, which is mainly on hospital admissions, next, please. Mefloquine users were at decreased risk of hospitalization and mood and severe mental health disorders. Next slide, please. And in the Schneiderman study, I think this is an important one. Next slide, please. They only looked at chronic morbidity, and they find, which I'm sure most of you recognize, that comeback and deployment were the main contributors to mental health outcomes and not the antimalarials or Mefloquine. And this was really also identified in ICOS, that it was the deployment, not the drug. In the 2 GP, the general practice database studies, next please. Mefloquine was not associated with increased depression diagnosis in either cohort analysis or in case control analysis. So compared to all the other antimalarials, there was not an increased chance of being diagnosed with depression or other diagnoses. Next slide, please. And this one, as I've already pointed out, next, please. The main finding from the Cochrane review was that Mefloquine was not shown to have more frequent serious effects than the other drugs, but the evidence was low. Next. But we know this from the original studies that they are more likely to have abnormal dreams and insomnia and anxiety whilst taking medication. Next, please. So, other than the research, there have been a number of groups who've been looking at the relationship of Mefloquine and the military, and this is an example. And so from the Australia on the top left, the Australian Parliament looked at it, the House of Commons here in the United Kingdom looked at it, the American Office of the Secretary of Defense in the Senate looked at it, and the Canadian military, the Surgeon General and Parliament also looked at Mefloquine in the military. And these reports are quite extensive, except for the House of Commons Committee, which was very small. And the one in the middle, the consensus report from the National Academies of Sciences, is probably the most comprehensive. Next slide, please. Their final summary is listed here, and they find that there was no current evidence or inadequate evidence to show an association of Mefloquine and persistent or latent neuropsychiatric disorders, including PTSD. but they suggest that the evidence wasn't good enough to make a stronger link, and there is some suggestion of biological plausibility, and they require bigger studies to actually answer the question, is there an association between the drug and latent psychiatric disorders? Next slide, please. So, in summary, this drug has been extensively used, but now is much less used. There's been quite a lot of epidemiological research in the military into latent and persistent disorders. To date, those have not been identified in relation to the use of the drug, but the evidence that we have is not necessarily good enough to make that determination. However, because of its reputation and its public perception, this drug has been either been withdrawn from markets or certainly been reduced, and there are very few organizations and military now using it as the first line agent, and therefore it is very unlikely that the question will ever be answered. So we are left with what we've got, but we can't answer the question. But currently there doesn't seem to be a strong association. Thank you very much.
Great. Well, thank you ever so much indeed, Ron, for covering what is, as you quite rightly said, a sometimes controversial topic. We've got a few questions, which I will do, but I will take Chair's prerogative to ask the first one, which is perhaps one that you might have a view on, but it could be open for debate. Is given that what you presented is that the evidence on Lariam doesn't tend to suggest it's as demonic a drug as many people claim, why do you think it is that it's ended up with this kind of reputation as being a neurotoxic horror drug, and people are very, very keen that it shouldn't be used when the evidence doesn't necessarily support that?
I think it comes down to my second or third slide when I showed many of the symptoms associated with our frequent symptoms in the population, and people then attribute it to the drug. And if it can cause insomnia and depression and vivid dreams, why can't it cause longer term neurological disorders or neuropsychiatric disorders? And that presumption, I think, is part of the problem. I think also in the groups that are most disturbed by it, or the military, they have other disorders which will have developed whilst taking the medication. And again, I think there's an attribution to the drug rather than the other environmental or occupational risks that they face. And I think these get conflated. And the Mefloquine story makes me think of the autism story in the MMR vaccine. And I think the population or the users want to be able to blame some product to their psychiatric disorder, and a drug is as easier thing to blame as possible. And that's my own personal feeling on it.
Okay, great. Well, thank you very much. So just got a few questions now, which the audience has sent in, and I'll kind of conflate the first two together, which is about, really when were the first side effects of Lariam as being indicative of more serious things? When were they first known? And someone's written, for instance, why did the World Health Organization warn and not advise the use of Mefloquine, Lariam, in 1989 when it was first licensed? So,
well, the problem was that study was just spontaneous random reports, and they weren't necessarily indicative of anything. There were about 1.2 million doses prescribed, and there were a couple of hundred severe neuropsychiatric events. Now, the problem is that because of a new drug, you're more likely to report an event, and whether it was causal or not could not be attributed, but they published it, and then people said, well, there must be a link here, and therefore from there, it's sort of developed, I suspect.
Okay, well, thank you for that, and I think that's interesting. One of the other questions later might sort of touch on this. Someone's asked if Lariam does cause damage to the brain, if it were to, might that show up on some sort of brain scan?
So there's been a lot of work done on that. There's no evidence from looking at anatomical investigations of brain damage. There's some rat work when you give large doses that the rats have some changes and behavior changes, but if those can be attributed to humans. A lot of people don't think so. The drug, once it's eliminated from the body, it's felt is unlikely to be causing the current symptoms. And so the decision is, there is currently no scientific evidence that it causes physical or anatomical damage to the brain. Therefore, to believe that the other point, of course, it may bring to light a pre-existing condition, and that's what a lot of people believe, is when you take it and you've got a pre-existing, you might bring it out, or the travel itself might bring it out.
Okay, great. And so I guess someone's written I think a great question is what does Professor Behrens think are the main lessons we can learn from the Lariam story and associated research? And I might just add my spin is that, if we come up with a new drug called amazepine or whatever that amazepine does, what could we learn from Lariam about the way to make sure that amazepine gets a rightful place in being prescribed when it should be?
That's a really tough question in a drug like an prophylaxis, because you've got to study people out of their normal environment. And I think that to prevent this from happening again, you've got to have really large studies in people in their normal occupational and travel risks, and taking into account their background morbidity and neuropsychiatric morbidity, to ensure that this drug is not causally linked to these sort of what I call nebulous, when I mean nebulous, that they were difficult to diagnose psychiatric phenomena. And it wasn't done in the original studies because of, as I say, the design to follow, a few thousand travelers across the world. You cannot exclude it. I mean, there have been some interesting studies of Mefloquine when taken at home, and they have much fewer side effects than when people take it when they travel. And that suggests, a bit like the work on deployment, that the changed environment has an important contribution to your neuropsychiatric health. And taking that into account in a prophylaxis is going to be very important.
Great. Well, listen, thank you very much indeed. It's been a really enlightening talk, and as you say, with these difficult subjects, it's good to have someone who's expert in the field talking about it. There's one for Ron, just who's allowing one. Has there been any studies done to try and estimate the number of military personnel, military veterans who might have been affected, in a negative way by Lariam in the long term?
That's difficult to answer because the causation is the problem. There are obviously and we've seen the statistics of people with neuropsychiatric problems after deployment. But what the causes, was it Mefloquine, or was it the deployment, or was it the trauma of the events that they face? So that's the big issue. So I suppose if you say that Mefloquine toxicity and PTSD are the same thing, and some are caused by Mefloquine and some are caused by environmental and occupational hazards, you cannot really separate the two. So does Mefloquine cause long-term neuropsychiatric is still a question, and therefore you can't say how many people have got it. You can do it when they have short-term, but you can't say it for the long-term.
Absolutely. I think that's actually very useful and a really good clarification, that we shouldn't try and jump to make estimates when actually we're not entirely sure what it is that we're actually estimating.